actually we're at 6 presentations, I'm sorry. And then we'll have our distinguished panel, our distinguished discussants here in our front row. Professors Ken Fox, Professor Stuart Biddle, and Pedro Teixeira. And they will be giving a feedback on the various presentations and providing some of their own insights and other data, and posing some questions. And followed by that, we will have about a 30-minute wider discussion with the audience. This is intended to be really interactive, and we hope we have a lot of audience participation, and so you can start clearing up some of your ideas and your questions as you hear the presenters. And the distinguished discussants and myself will try to take this area where we can in the next 30 minutes. So we're in the final 30 minutes. So our first presenter is Deborah Dewar, and from Newcastle, and her title is a longitudinal study of physical activity behavior in adolescent girls from disadvantaged schools, a test of social cognitive theory. Thank you, Deborah.
First of all, I would just like to acknowledge and thank my supervisors, Associate Professor David Lubens, Professor Ron Plotnikoff, and Professor Philip Morgan for their support during my PhD candidature. Now, Bandura's social cognitive theory has emerged as a prominent theory of health behaviour for guiding physical activity interventions in youth. However, very few studies have actually examined the hypothesized pathways in Bandura's social cognitive theory model to explain physical activity behaviour in adolescents. In short, the model suggests that self-efficacy is the central determinant to health behaviour because it influences behaviour both directly and indirectly through other determinants, specifically being outcome expectations, goals, and socio-structural factors. So the current aim here was to test Bandura's model, as shown here, to explain physical activity behaviour over a 12-month period in adolescent girls living in low-income communities. Now, considering the low levels of agreement that we have seen in the past between self-report measures of physical activity and objective measures of physical activity, a secondary aim was to compare the utility of Bandura's model to explain physical activity behaviour using both a self-report and an objective measure of physical activity. So data were obtained from participants in the nutrition and enjoyable activity for teen girls obesity prevention intervention, and subjects came from 12 secondary schools located in low-income communities in New South Wales. The girls were in grade 8 when baseline assessments were carried out. Now, because this is a longitudinal analysis, baseline data from 4 social cognitive measures relating to moderate to vigorous physical activity were used, while 12-month outcomes for daily moderate to vigorous minutes were also calculated from the accelerometer output and a 7-day physical activity recall. Specifically for the current study, socio-structural factors included a measure of parental support to be physically active, and while the intentions are regarded proximal goals in the social cognitive theory, we included intentions to replace the determinant goals. So looking at our analyses, structural equation modelling was conducted to test the hypothesised pathways in the model, and to examine model fit, the model fit indices shown here are also reported. So both the models predicting self-report and objectively measured physical activity, the fit indices were adequate to support model fit. So in interpreting these results, the norm to fit index and the comparative fit index needs to be larger than 0.9 to be acceptable, and the standardised root mean square residual needs to be less than 0.8. So looking at the model that predicted self-report physical activity, we found that 3 of the 8 hypothesised pathways were supported, as shown by the filled in yellow arrows. So that is from self-efficacy to outcome expectations and parental support. and from outcome expectations to intention. Meanwhile, 37% of the variance in intention was explained, but only 8% of the variance in physical activity behaviour was explained. So this time looking at the model that predicted objectively measured physical activity, the same three significant pathways emerged. And once again, however, there was no support for the pathways leading from the social cognitive constructs directly to behaviour. Again, 37% of the intention variance was explained, but this time slightly smaller variance in physical activity was explained being 4%. So in summary, in comparing findings for the models predicting self-report and objectively measured activity, the outcomes were very similar. The stronger variance explained for intention rather than physical activity behaviour is consistent with findings from earlier research, which may suggest that good intentions to be physically active don't always translate into action. The fit indices indicated that both models were a good fit to the data. However, none of the pathways from the social cognitive constructs to behaviour were supported. So where to from here? Well, continued research could, or is needed rather, to closely examine the interactions between the social cognitive theory constructs and possibly expand the hypothesised pathways. So, for example, could implementation intentions bridge the gap between intention and behaviour? Finally, future research may focus on the predictive power of integrated theory to try and understand the underlying mechanisms that do drive physical activity behaviour in adolescents. Thank you.
Thanks, Ned. Any one quick question or point of clarification? Great. Great for Ned. I'll go with that. Our next presenter is Jens Tjolsen, who is speaking on settings. I'll just bring up the slide here. On developing of a specific physical activity behavioral model. Thank you.
Thank you. I will start saying I'm not sponsored by Coca-Cola, but I have three strong Danish foundations in my life and the Danish Cancer Society that support this research. What I'm going to do is make a short presentation about the need for developing a site-specific behavior model, paying attention to the fact that we need to be aware of local and cultural factors when we develop interventions. And just to make sure I reach to the conclusions, I would say that we should use ecological models as a theoretical framework in developing intervention. It's very important. We should also develop a model paying more attention to the site-specific behavior. And doing that, make very detailed analysis of all the local factors related to physical activity. So now I've got that in place. Most of you, I assume, are aware of the social ecological models. This one is paying attention to the four domains of active learning, active leisure, active transportation, work-related activities, and domestic activities. And it's a very good model to comprehend the multiple levels of factors influencing physical activity. And what this model is saying is that it should be behavior specific. What I would like to add to this model based on Danish intervention studies is that we should pay attention to a size-specific layer like this. This model pay attention to the different characteristics in the built environment, the schools, playgrounds, work sites, and so forth. But each of these factors has to be more local when we look at them. If we, for example, look at some Danish intervention studies, we have some types of facilities that are almost the same, but we see different kinds of outcomes. This is two examples of playgrounds. They are empty. unfortunately, in this picture. But they are they cost almost the same, but we see different kinds of behavior. Another example is the space project, big Danish intervention studies. We see different outcomes, even though we have the same type of facilities. Of course, they are on a different location. There's different kinds of local aspects involving these. But there could be, for example, in these two examples, different strong communities with different preferences. One would be for street basketball, one would be for skating or parkour. It's one of these examples. And that influences the physical activity behavior. So, I think I'm on time. Just to make sure, my take-home message for you is that you should use ecological models combined with site-specific analysis to develop physical activity interventions. Thank you.
Thanks, Jens. A question? Any questions? Yeah, Stuart.
Could you say a bit more then about what particular features of sites you think are most crucial in this? I mean, we gave two playgrounds.
Yeah, playground is one, and I would say school site as well, because we see very different local, different kind of cultures. How to organize the school site, for example. You have to look at that to be aware of that when we're developing.
Well, this actually was what I was thinking, that even though they're physically slightly different, that might not be the issue. It might be that who's using them or what the local social concept.
Exactly, and that we have to be aware of that when we're developing, especially kind of intervention that we're doing. If that also influences, also take use the built environment.
Okay, thank you. Is Dr. Graham Baker here? Yes. Dr. Baker's presentation is on examining the theory and evidence to inform the development of an active community commuting intervention and iConnect case study.
Well, good afternoon everyone. So it's commonly cited that interventions based on health behaviour change theories are more effective than non-theory based interventions. Yet, many times reviewing these studies, we're often left with the question, how is theory actually being used in the study to influence or change behaviour? So this presentation is part of a larger study that's examining active transport called iConnect. You can find out some more information on iConnect at the website. The specific aim of this presentation was to examine the theoretical basis of previous walking and cycling interventions. So we were interested in what theories have been used previously, how these were linked to behaviour change, and how these could help us target important constructs. So we conducted a systematic review on walking and cycling interventions, and specifically on adult studies. We updated previous reviews that had targeted these behaviours, but we focused on individually targeted interventions. And we included published, randomised, and non-randomised studies. The studies had to include some sort of control or comparison group, and they had to provide before and after outcome measures. So in our analysis, we included 41 studies that described 46 distinct interventions. And we categorised these into 3 groups in order to explain and examine differences in outcome and study characteristics. So in our first group, we had 21 interventions and produced a significant positive effect on behaviours. In our second group, we had 12 interventions that produced no significant effect. And in our third group, we had 13 studies which did not actually report the significance of the effect. And in order to extract relevant theoretical information, we used a 19-item coding scheme developed by Mickey and Prestwich, and which covered 6 major components, such as the mention of theory of model behaviour, targeting of relevant constructs, and the measurement of these constructs. Given the time limit today, I'm only going to focus on 2 of these aspects. The first one being the mention of theory model behaviour. So that was the intervention actually describing what model it had been based on, if any. And the second component, which was targeting of relevant constructs, which assesses the extent to which the relevant constructs were targeted and also how these were targeted via specific behaviour change techniques. So from the findings, we can see that of the 46 interventions we analysed, only 15 of those actually mentioned that we had some form of theoretical base. We can see that the majority of these were based on the transferential model or social cognitive behaviour. And from the table, we looked at how this broke down from our different outcomes, different categories based on outcomes. So we can see here that for those 21 studies that produced a positive effect, about half of those were theoretically based. And we can see how this decreased through the different categories, and we found a significant difference between studies. A proportion of theory-based interventions were higher in the positive effect category compared to those where the effect was not reported. What we did find was that theoretical constructs via targeting, there was really limited reporting of these. So for example, self-efficacy in social cognitive theory. And we also found that there was considerable variation in the frequency of behaviour change techniques that was reported both within and between studies. So between our categories, we found, for example, a significant difference in the number of behaviour change techniques that were used in those interventions that produced a positive effect in comparison where in those interventions where the effect was not reported. And even within categories, within those 21 interventions that produced a significant positive effect, we found a range of ECTs of between 0 and 12. And there were actually very few examples of where the proposed causal pathways were actually explicitly described. So that I mean between an individual technique or cluster of techniques, how that was actually linked to an individual or cluster of predictors and constructs. So in conclusion, we found some further support of theory-based interventions being more effective than interventions that were not based on theory. However, what we did find more important was that there is really limited evidence on how theory is actually being used or has been used in previous walking and cycling interventions. So we would suggest that future studies should provide a clear justification for the use of their specific theory model and make sure that the proposed pathways of behaviour change are fully explained in relation to the constructs and behaviour change techniques used. We need to ensure that these constructs are actually measured and also then subsequently tested in order to refine and develop theory. So thank you.
Thanks, Greg. Dave. Thanks for the presentation. Very interesting. Just wondering, did you, looking at your review, a lot of studies will now obviously have a protocol paper and probably subsequent mediation papers that will test those pathways. Did you include that as part of it?
No, we did. As part of the main aim of the study, which was to examine behaviour change techniques, we also coded the intervention content that was described in any additional methods papers, and they were very, very few. That's something we did consider. Also, we did examine if there were additional mediational analysis papers, and again, these were really limited and we didn't add anything to the actual analysis.
Did you contact authors to sort of follow up and sort of say, have you published it?
Yes, no, that's what we did. Yeah.
Great. Okay, and again, we got great opportunity at the latter third of the session to follow up on a lot of these issues. The next presentation is Professor Ken Fox. Thanks, Ken. Yes, I can do that. And
Okay, this presentation from the title was intended to be a little bit longer than 5 minutes, so it's selected. Okay, I wanted to give an idea of the way we're applying theory to interventions. I spent a lot of time trying to develop theory in self-esteem. Moved from that to being a user at Bristol, where we've got to the point where we're designing interventions for a range of populations. So I've chosen two just to highlight some of the things we're doing. One is the TREAD project, which is now complete, and was to work with a depressed population in primary care. Now, the population clearly has low self-esteem, low motivation, and a sense of hopelessness, very challenging, so we needed to tailor the intervention to those needs, and so we chose self-determination theory because it fitted a lot of what we needed. Self is the agency of change in self-determination theory. Behavioural will talk more about this particular theory, so I'll rush through it. But it really targets helping people feel competent, autonomous, and affiliated. And these are seen as human needs, psychological needs that need satisfying, and that seemed to fit our population in particular. Also, it fitted with the kinds of strategies we wanted to use to move from prescription to facilitation, to engage people in choices and preferences, because we couldn't force them to do anything. And it had a good fit with motivational interviewing and cognitive behaviour therapy, which is the way we wanted to deliver. So the components were delivered through primary care, physical activity, facilitator, training, counselling and motivational interviewing. And all they got, the patients that is, was four face-to-face sessions and up to 10 phone sessions. So it wasn't that intensive when compared, for example, to cognitive behaviour therapy. And that's written up in that paper that you see there if you want to learn more. Outcomes, we unfortunately have no evidence of impact on symptoms of depression given this intervention, but we did have evidence of small increases in physical activity that were sustained, and the patients and the facilitators themselves really were supportive of the intervention. They believed it did a lot of good. Now, you could conclude from this that we should drop the theory. That's not our choice. We think that actually it did work for a lot of people, and we need to find out for whom it works well, and maybe tailor it better, and maybe need a more intensive intervention for those who didn't work. So we'll take it further rather than abandoning the theory at this point. The second descriptor is something quite different. I got a chance to work with a slimming organisation in the UK who wanted to add activity into their delivery system. So it gave me a chance to access a very large number of very large people and introduce them to exercise in their lives, because most of them went to Slimming World not to exercise, but to lose weight. So they are a group of participants who are driven to lose weight, largely lacking in competence, largely not understanding exercise, not convinced by its value, so we had to use a slightly different approach. So we used self-perception theory and identity change theory through physical activity. We felt it needed an education and attitudinal component that was quite strong because they weren't convinced of the benefits of exercise, particularly for weight loss. And we focused on positive health motives, a little bit like satisfying needs, psychological needs, and those are the some of them listed. And we use modelling as well. Slimming organisations often feature on the front of their magazines people like their participants who have lost weight successfully, and participants can believe that they can do themselves. So modelling is used. We couched it, we presented it in a framework that I wrote a long time ago for a book by Tom Wadman on treating severe obesity. So it was a stage model, and so we figured we needed to tackle psychological commitment first, which is attitudes and knowledge and understanding, before we went into behavioural strategies to change behaviour. Okay. Hopefully intrinsic motivation for physical activity will be the outcome. They have a very successful publishing side to their business. Obviously it's a commercial organisation, and they presented this information in the terms that their population could register, so they got their attention very quickly with these kinds of materials. They're all materials we've seen before, but presented in a slightly different way, and obviously these tackle different elements of psychology. There's the modelling one featuring not necessarily glamorous models, but people who want to improve their health as well as lose weight. Outcomes, enthusiastic reception from the company and the participants, and they're currently planning a trial to see if it actually works. We haven't done that yet. Overall lessons learned, we think a selective approach to choosing theories and specific constructs is helpful. They need to be compatible and integrate well with each other and have a good fit with the characteristics and needs of the population and setting.
Great, thanks, Ken. And before we go in, there might be a quick point of clarification. I do like these 5-minute presentations because we get to stand every 5 minutes, potentially for some of us, and we will be extremely healthy by the end of the conference. Any quick question or points of clarification for Ken? Dave?
Very interesting. What was your adherence like with your depression trial in terms of adherence sessions at all?
Well, they weren't attending sessions, they were undertaking their own programs. So we tried to keep record, they tried to keep records of it, so they wasn't willing to attend a particular activity session. So, the compliance to the program was pretty good, actually, down to 85%.
Great, thanks very much. Our next presentation is from Professor Stuart Little, Reducing Sedentary Time in Young Adults at Risk of Diabetes, Project STAND.
Thank you, Ron. Good afternoon, everyone. So when I was asked to contribute to this session, it was to what I like to do on theory, so I thought I would just illustrate something we're coming to the end of, which is on Project STAND. And Project STAND is an acronym for Sedentary Time in Diabetes. Do you like it? Good, it was my idea. That's my only contribution within 3 years of the project. Not quite true, but close. So this is funded by the Medical Research Council as part of another wider initiative, and it's with my colleagues and friends at Leicester. So the idea is that we have a randomised trial around structured education to reduce sedentary behaviour. There's some self-monitoring in there that I won't mention much about, control arm, follow-up phone call and prompt, and some clinic visits, obviously some baseline assessments here. The key thing is that this structured education session based around what is known as the Desmond protocol, which is quite well known within diabetes research, around wider lifestyle behaviour change and subsequently some physical activity behaviour change. So when I had conversations with colleagues, I said I was interested, sorry, I want you to go back, I don't want to go there, back, again. I said that why don't we apply that model to sedentary behaviour, which at the time, because we're pretty much 3 years into this now, there were very few interventions. So that's what we did. They do a lot of monitoring, self-monitoring, which is discussed within the workshop, and some quite nice professionally produced materials to stimulate discussion within this 3-hour workshop, led by 2 trained health professionals. We've done some initial qualitative work around sedentary behaviour with this group who are at risk of diabetes but don't have diabetes, younger adults, maybe around their 20s and 30s, develop a curriculum and conduct a trial. So the main thing as far as this presentation is concerned is there are 3 facets to the workshop. So you have what's called the patient story, and the theoretical underpinning is Leventhal's common sense model, give participants a chance to share their knowledge of perceptions of risk, that kind of idea. Move into what's called a professional story, also common sense and some attitude models, some visual aids, questions to overview, in this case healthy glucose metabolism, factors associated with diabetes and risk, and then so let me just say something about the common sense model then before we go into the 3rd phase. So this is a theory that's not really been used so much in the physical activity sedentary behaviour domain, but has been in other areas of health psychology. And it is about illness behaviour. That could be an interesting issue to discuss when we have the panel. Essentially you've got the individuals making some kind of mental representation of risk and illness, which might lead some kind of help seeking or strategies to avoid or manage their illness. There are 3 basic sources of information around this theory. One is lay information, which obviously you get from previous communications and wide knowledge in your culture. External social environment, which might be authoritative sources like your physician, your doctor. And obviously some kind of current experience of the illness as to whether it represents fairly demanding symptoms of yourself or whether it's fairly benign. And these make sense of the illness, and hence the term, the model, common sense model of illness. And we built that in then to some interviews with similar type of people, such as, what do you know about diabetes? What do you think, why do you think people get diabetes? Because there's got a lot of misnomers around some of these health outcomes. What would increase your risk? How would it affect you in terms of your health and so on and so forth? Do you know anyone who has diabetes? And if so, how does this affect them? So we get them to engage in that, which helps us then to bring hopefully some more relevant material into the workshops. If you were to develop diabetes, when might this happen? Are you at risk? Is it only for old people? Is it for the people of age? A lot of them come into this not really thinking that they are at risk. So finally, we then get into the sedentary behaviour side of it, which has some feedback from active power, objective monitoring, things around self-efficacy for behaviour change, behavioural choice theory, which would be around issues such as discussing access and availability of sedentary behaviour and making alternative behaviours more reinforcing and enjoyable. So that's my whistle-stop tour of some theoretical approaches to our standing intervention. Thank you.
Thank you, Stuart. Question?
We'll, yes.
I'm sorry, that was really helpful. But can I just ask you the questions as you begin that interviews? What do you think of diabetes and why do you think you get it? If you don't get, obviously you have a scripted interaction or like an algorithm that you use. But do you bring in autonomy, supportive language? Do you bring in properties of, for example, of MI? What if the patient doesn't engage in the way that you expect and takes it off on a completely tangent and doesn't follow that sort of?
Okay, so those excuse me, those those questions were preliminary interviews to help us get a better handle on what these kinds of people might be thinking. They weren't part of the workshop. They fed into the workshop to help us perhaps deliver the workshop with material and issues that they would engage in. Does that make sense?
So that was more mapping, really.
Yes, yeah, that comes before we even go to the workshop.
Okay, any other burning questions? Okay. Thank you very much, Stuart. Our next presenter is Professor Pedro Teixeira, and who is presenting on applying self-determination theory and motivational interviewing to weight loss control.
Thanks. Well, in 5 minutes, it's not what we thought about early on in the game, but we'll, before the goes on. Okay, so let's see what we can do. So despite a lot of common knowledge about nudges and mindless habits and switches, tipping points and so forth, some of us still believe that motivation is still a useful thing to think about when you think about behavior change, especially when you think about sustained behavior change habits that last a lifetime, something which I like to call chronic motivation, as you might see the analogy there. So we turn to the theory one theory that does provide an in-depth analysis of motivation. It's been developed for a long time and has been subject to multiple applications, as you can see. And we did it for mainly for 3 reasons. First, because it does provide a nice rationale for sustained behavior change. It explains the process by which behaviors get internalized, get integrated into one lifestyle through more autonomous forms of motivation. It does provide clear guidelines for interventions, for intervention targets, and motivational interviewing is something that goes along with that very well. And finally, because it does put behaviors in context of people's aspirations, values, psychological needs, and it does, in a sense, it predicts well-being as well. And these aspects, among a few others, make this theory quite unique in terms of the most common theories applied to health behavior change. One feature of STT is its qualitative approach to motivation, in which motivation has different types and not just levels. So it's not just how much motivated we are, but what's the nature, the elements of that motivation, and the critical distinction is between autonomous and controlled forms of motivation, which I really don't have time to describe in much more detail, but I think you have the point: more internal, more autonomous. And it provides then predictions as by which different forms of motivation affect different outcomes, health outcomes, behavioral outcomes, and so forth. So the question is really which types of motivation work best for long-term active living, not so much how much motivation. And I'll present very quickly results from a recent systematic review and from a trial in 2 minutes. So we just concluded this review. It's been published just a few months ago. We found 66 studies that have used self-determination theory to explain behavior or behavior change. And the summary results are compatible with the premises of this theory, in which more controlled forms of motivation were negatively or inconsistently related to behavior, whereas autonomous motivation was very consistently associated with behavior, even though a new aspect that we were able to detect was that perhaps more intrinsic forms of motivation, which is slightly different, or the category of autonomous motivation, is more predictive of maintenance or behavior change in some of the longer-term studies. One of them was a study that we conducted that you can see here. Is the PISO study was a 3-year randomized control trial with a 1-year intervention in overweight and obese women. We used the STT model for behavior change, looking at the 3 needs that Ken just briefly described before as the sources or the origin, being in the origins of formation of more autonomous forms of motivation, which then would predict sustained behavior change. Just to give you a flavor for the intervention, these are like some of the key features in which we think that people are really the experts of their own course. We elicit individual values, individual goals or life goals, life aspirations are very much a part of the intervention, or integrating them with behavior change. So the idea is really for people to develop ownership over physical activity behavior to make it a meaningful endeavor. And we can say that this is a person-centered approach. It comes from a humanistic perspective, and it's also very much a process-based, so the experiential components of physical activity and healthy eating as well, this was a weight control intervention, are very much have a high focus on this trial. So some results, 2 years, so this is a 1-year intervention. We're looking at 2-year results after 1 year without contact. We were able to detect a 1 hour and a half mean difference in moderate vigorous physical activity. This I'll go very quickly. This is just an action test that we conducted to see if we did affect the mediators. We did. These are the conceptual theory tests in which we looked at mediation, so the significance of the indirect effects by which the intervention would affect the outcome through autonomous motivation. And this is the full model for 2-year physical activity, in which you can see the significant paths as expected, going through autonomous motivation at 1 year, at 2 years, and then behavior at 2 years. Just another way to look at it, by tertiles of autonomous motivation, 2-year levels of physical activity in minutes of moderate and vigorous physical activity. We also have 3-year results now, and they show the same differences that we observed in 2 years for the 3-year analysis. And we also looked at the different form of physical activity, which we call lifestyle physical activity, but it's really about sort of the absence of sedentary behaviors. And you can see some examples here where we also notice some differences after 3 years of the beginning of the intervention. And this is also predicted by motivation that I don't have much time to explain further. So, key points. We explore this qualitative approach to motivation as the basis of long-term physical activity adoption. It did mediate the outcomes that we were targeting, in this case, both moderate and vigorous and lifestyle physical activity. Next, we'll move to other types of studies where we will focus on intervention fidelity and also looking at some active ingredients of the intervention. And for this purpose, motivational interviewing will be used with a bit more detail in the future because it fits well with STT. this is just a series of papers that came out looking at the interaction between self-determination theory and motivational interviewing. And for those of you that might be interested in the topic, the conference next year of the International Society of Behavioral Nutrition and Physical Activity that will take place in Ghent will feature, among other theories and other topics, also some some lectures and sessions on self-determination theory. Thanks very much.
Great, Pedro. Question? You got through pretty well. That was great. Yes, at the back.
I just have a question about self-determination theory. So is this something that works with everybody, as in anybody can develop this intrinsic motivation, or are there some people who are sort of stuck with having to rely on extrinsic motivation?
Right. It's a great question, because we also heard before that we might want to select theories in regards to our population. In fact, predictions from self-determination theory should be applicably in a universal fashion. So supposedly, if we do endorse these ideas, these basic psychological needs are operative in all of us, in different environments, across cultures, different age groups, and so forth. So it's been applied in different settings, in children, in adults, in education, in health, and they have been consistently confirmed as being operative.
And then is the idea behind external rewards not working in the long term, is it just because you always have to provide them, or is it that they become less useful, people are less sensitive to them over time?
Right, because they really don't contribute to whatever makes autonomous motivation more meaningful to you. So, in fact, it is true that you have to keep continuing to provide them to keep the behavior sustained. And indeed, studies show that when you do stop providing them, because you don't have an internal source of energization of behavior, the behavior tends to disappear. So in the long run, people tend to stick, and the quality of behavior is enhanced. The quality and the amount of behavior is enhanced when indeed the sources of motivation are more internal.
Great, and we can certainly follow up on some of this in our discussion a little bit later. The next. Oops. Yeah, the next presentation is myself. I'd like to acknowledge my co-authors, David Lubens, Chris Van Holt, Kerry Crinier, and especially Dave, who tortured these data. It's important to understand the mechanisms of change in physical activity. I think that's become quite apparent. A few studies have conducted mediation tests, however, with objective physical activity measures. The Alberta Diabetes Physical Activity Trial, or ADAPT study, developed and evaluated 3 intervention strategies for adults with type 2 diabetes. One of the intervention strategies was efficacious for women. Secondary analysis of women in the ADAPT study was conducted to explain behavior change. So the aim of the study was to investigate potential mediators of objectively measured physical activity behavior change for women in this particular study. A bit of background on this. Participants were randomly assigned to one of 3 groups. A standard group that just received Canadian Diabetes Association print guidelines, a tear-off sheet. Group 2, the guidelines plus stage match booklet for 3 months on a polytheoretical approach. We combined 4 theories: theory-defined behavior, social cognitive theory, protection motivation theory, and the transtheoretical model. And what we did is, from an earlier longitudinal study of this population, or another population, we found over a 2-year period what were the best predictors of physical activity. We tested all these theories in a very large sample of 2,000 people over 2 years, and we designed our integrated approach, our integrated stage approach to predict what are the best predictors of behavior change in this population. We also included pedometers and logbooks. So I was at group 2. Group 3 received all the above interventions plus telephone counseling based on motivational interviewing. 12-month intervention, mean age of the woman about 60 years, no difference between the groups on key characteristics. We employed valid and reliable measures based on this population at baseline and at 12 months for the a list of social cognitive constructs. And then we assessed daily steps, 3-day steps, baseline at 12 months with a IDMX DigiWalker. The brief outcome here is steps increased for the control, or for the group 3, the full intervention group versus controls. The mean difference for the 3-day steps count over the 12-month period was about 4,000 steps. So we conducted mediation analyses with the women in the control and women in group 3. We followed the Preacher and Hayes as we assess macro protocols to examine the action theory, the conceptual theory, the significance test of the product coefficients. This approach is deemed to be quite appropriate for small sample sizes. And we analyzed this by residualized change scores for the cognitive mediators and the behavior measures. So briefly, the action theory, the intervention effect on the social cognitive measures, the change of social cognitive measures, the conceptual theory, the change in social cognition measures, and its association with the change of physical activity, behavior over a 12-month period. And again, these were computed by visualized change scores, and the following analyses are reported as unstandardized beta coefficients. So the action theory, group 3, the intervention group, significantly increased their implementation intentions, their intention, self-efficacy, and perceived behavior control. The conceptual theory, so controlling for intervention effects, increases in positive outcome expectations, attitude, and perceived behavior control resulted in an increase in total steps, and intuitively increases in cons and vulnerability, having further diabetes problems resulted in decrease in total steps. The key findings here, the significant mediated effects of the models that intention, perceived behavior control, and barrier self-efficacy were your key significant constructs. The proportion of the intervention effects mediated by intention was 23%, PBC 18%, and self-efficacy 24%. So, taking these data in their entirety, we can conclude that intention, perceived behavior control, self-efficacy are certainly important mechanisms of pH change in this target population, and behavior strategies such as goal setting and overcoming barriers may indeed be salient for designing interventions that women in this target population. I hope, if you have any questions, I hope it's easy. And if it's hard, ask Dave.